And I'll give it a couple seconds after it starts. All right. I see people trickling in. Hello, everyone. All right, welcome to the Neuroblastoma Parent Global Symposium. My name is Kyle Matthews. I'm the Executive Director of the Beat Childhood Cancer Foundation, and I'll be moderating this session. This session is DFMO Studies at the Beat Childhood Cancer Research Consortium, and it's being delivered by a friend of mine, Dr. Javier Oesterheld, who is the Division Chief and Jeff Gordon Children's Foundation Endowed Chair of the Levine Children's Cancer and Blood Disorders Program at Levine Children's Hospital Atrium Health in Charlotte, North Carolina. Before I hand it over to Dr. Oesterheld, I do want to draw your attention to the Q&A button, which will be at the bottom of your screen. That's how you can submit questions during the session for Dr. Oesterheld to address at the end. If the button's not showing up, you might need to kind of hover your cursor or tap, and then you'll see those buttons across the bottom, and the QA one is usually on the right. If you see a question in the Q&As that you like, you can give it a thumbs up to move it up the list. And when Dr. Oesterheld is finished with the presentation, we'll be answering the ones that have the most thumbs up, sort of in that order. So that'll let us know if those are ones that you would like to see answered. All right, with that, I'll hand it over to you, Dr. Oesterheld.
Thank you, Kyle. I really appreciate that. Is that sharing the screen? Hello?
I did not see the screen yet, no.
Okay. We had it up. Technical difficulties. We will get it.
I think you just want to mouse over and hit that share screen button. It should be in green, at least on mine it is.
It is on mine too. And let me apologize, everyone. All right, that should be it.
Yep, perfect. I see it now.
All right. Wonderful. All right, thank you, everybody. I apologize for that technical difficulty. I just wanted to thank the organizers for allowing me to speak on behalf of the Beat Childhood Cancer Research Consortium about DFMO treatment for high-risk neuroblastomas. Kyle so eloquently introduced myself. I am the division chief at Levine Children's Hospital in Charlotte, North Carolina. And since I am speaking to a few parents, I am the father of two boys, a 13-year-old and a 10-year-old. And a little bit about myself. I'm originally from Puerto Rico, been married for almost 20 years now, and been down in Charlotte, North Carolina for about 18 years. Really excited to be able to give this lecture today. To talk about the Beat Childhood Cancer Consortium, it's been an incredibly big year for the consortium because it has moved. It was at Spectrum Health, Helen DeVos Children's Hospital for the last decade, and is now at LCH. Dr. Schiller and her team moved in July of 2020 during the COVID pandemic, which added a bit of stress. As you can see there on the globe, it is 42 hospitals in the United States, 7 hospitals in Canada, and 1 hospital in Lebanon. This consortium has continued to go over the last really 4 or 5 years, really taking off and adding new studies and new members, and really delving into the science of neuroblastoma and some other tumors that we take care of. The new headquarters at Levine Children's ties itself with the Levine Cancer Institute, which is one of the larger cancer institutes in the Southeast. Allows us to have a little bit more bandwidth, obviously more patients with a improved international airport. We're incredibly excited to bring the shoulder lab as well to Levine's, and really going to talk a little bit about what we're going to be doing in that lab. But into the talk and treatment of high-risk neuroblastoma, which obviously most people in this audience understand that it is a mixture of induction, consolidation, and maintenance therapy. And so I won't go through this too intently, but combination chemotherapy, which is fairly aggressive, action of stem cells in most centers in the country, followed by surgery to resect most of the primary tumor, as well as followed by either a single transplant or a tandem transplant, and tandem is considered the standard of care, followed by radiation therapy. And then I think with DFMO, hopefully we'll have a place in our therapies is in maintenance therapy with antibody as well as retinoic acid. Maintenance response, which has been very well published from AMBL 0032, a COG study. These patients were randomized to receive the antibody as well as this retinoic acid. As you can see the numbers there, it was a really pivotal trial for the neuroblastoma community in improving event-free survival and overall survival, as you can see there in the data. So why DFMO and why do we think it's an important target? You know, the reality of this is that it is, because it blocks ornithine decarboxylase, we don't need to remember that, but it decreases polyamines. We know very well that in neuroblastoma stem cells, as well as in the cancer itself, that polyamines are overexpressed. And so logically, we would want to try and drop that and inhibit those. And we can see that inhibition of polyamines decreases in the urine as well with the use of DFMO. It also reverses an incredibly important pathway called Lin28, which is shown to be perturbed in many different cancer stem cells and different types of cancer. And also, as many of us know, MYC amplification portends a poor prognosis or makes you a high-risk patient at times. And so DFMO also suppresses that. This is just a fancy picture to let you know that there is some science and some pathway behind it. Now, this is really, I think, where at least when I started hearing about the DFMO story about 10 years ago, where I think a lot of our interest lies is the cancer stem cell. And so our many groups and labs and places across the world really looking at the cancer stem cell and understanding that after chemotherapy, that stem cell can still remain, even though we cannot capture that with any sort of MIBG, CT scan, MRI. But we know that there's a population of stem cells that are there that always are present and can allow the patient to relapse. And so obviously that subpopulation, very, very important. And so these cancer stem cells can self-renew. They can generate differentiated cells that can grow the original tumor again. And then unfortunately, the cancer stem cells has been kind of shown in sarcomas, also in Dr. Scholler's data for these stem cells, is resistant to modern cancer treatments. And so you feel that you are shrinking the tumor and improving it, but unfortunately you're leaving behind these cells. This picture here is just to show you can have your tumor and then therapy. Obviously, you can get tumor shrinkage and improvement, but unfortunately these cancer stem cells remain and then they turn into a relapse. And that is really the population of cells that DFMO is trying to target. This is showing very elegantly done, has been readdressed also in the Scholler lab from DFMO selectively killing CD114 positive cancer stem cells. Just this graph, and I won't go too far into it, but this just shows in little red area, these stem cells continue to decrease as you increase the amount of DFMO given in obviously in vitro in the lab. And this is on 2 different neuroblastoma cell lines. And so exciting to be able to show that DFMO continues to inhibit these cancer stem cells, which is where the data for DFMO and maintenance really evolved. Lots of slides, and I apologize for the kind of graphs, but I think they tell an important story. Is when you see 2 different cell lines here, the top and the bottom are just showing that once DFMO is added at very small concentrations, these dropping graphs just show you that you have cell kill in vitro as well, and also in mice models, which is really the preclinical work that led to the DFMO trials that we're going to talk about. And so that's kind of the science leading up to that and telling us that inhibiting polyamines as well with a drug that, as you will see, is incredibly well tolerated, is an exciting opportunity. So the DFMO is maintenance therapy. This therapy is after high-risk therapy, as you can see here. And so really what it was based on the data from 0032, from COG and Dr. Hugh, and really showing us that after that time point, if you could get patients on this study with no evidence of disease for 2-year mark, the goal was to improve event-free survival, or the chance that that child would relapse, and then obviously improve overall survival at the 2-year mark. The dose, as you can see there, is a low dose. We've upped that dose a little bit, which I'll show. And then there were two different ways that you could get on the study, which was patients at the end of therapy, which I just described, or patients who had relapsed or become refractory to neuroblastoma, but then again were put back into remission. I apologize for all these slides, but I think that these are really kind of the story of DFMO in maintenance therapy, recently published again in 2020 for updated data out 2 and 4 years. And so I'll walk you through these a little bit just for importance. These are patients that are all comers. As you can tell, the event-free survival at 84% of years is pretty well maintained until the 4-year mark, which is really what we are excited to see. With any intervention, you're worried that that effect may drop off and that patients would relapse after that therapy. And the data shown here does show that we have been able to maintain those numbers throughout the therapy. MYC amplified patients do as well as non-MYC amplified patients. As I noted, that polyamine inhibition is important in MYC, but it's also noted that we are affecting the cancer stem cell in non-MYC amplified patients where we think that this is. And then we are currently working with the Children's Oncology Group and comparing the data from some of the BCC sites as well with the patients that were enrolled on 0032 and then went on to DFMO, which you can show there. The data seems about the same as well there in that population. So if you look at this, another slide, this one is very important because these are patients who had their cancer come back and then were started on DFMO. Obviously, these numbers, we would love to see them improved, but in patients that had relapsed refractory neuroblastoma, we've made a lot of headway. There have been many clinical trials through the Children's Oncology Group as well as other groups, and BCC included, that have started to kind of improve that needle of patients who have relapsed or become refractory to keep them alive and not relapse. And you can tell that DFMO in that patient population, again, being in remission going into DFMO, still showed a 50% 2-year event-free survival and a little bit of a drop off at the 4-year mark, as you can see. Now, this is a really exciting analysis that I just mentioned that we did publish, and this is data showing about 80 to 100 patients, depending on how you look at this data, treated with DFMO for maintenance therapy, as I mentioned. And this just shows again that the patients who did not receive DFMO and the patients who did receive DFMO do have a statistical significant change in their event-free survival as well as their survival, and you get those numbers there. And obviously that is what has gotten us excited. And so with that data, this is just another one showing kind of a similar finding. Patients on MYC amplified, it's a little bit more dramatic in the MYC amplified patients. As you can see, the data there is a little bit higher. Now, this is where I think kind of primarily this talk really is important to get out there is we have been granted, or BCC and Dr. Scholler and a bunch of people prior to Levine Children's Hospital were granted breakthrough therapy designation by the FDA in April of 2020. That's incredibly important just because not many pediatric drugs, especially for pediatric cancer, get to market. And so, as I mentioned, we are working to directly compare data to the COG data, and I think that hopefully will show that there is a survival benefit. So important notes for parents and patients who do want to go on this study. It is open to children at the completion of antibody therapy. The prior study was up to 120 days. Now we have changed that. There's some data showing that the faster you start it, the better those patients will do. The initial arm, as I showed, did show lower doses. We have changed that dose to a little bit of a higher dose, as you can see there, still with limited side effects. And that is currently enrolling at all beach childhood cancer sites. So I think most important, what are the common questions for DFMO? And I should have shared that, but I have enrolled probably around 20 to 25 patients prior to BCC being at our institution. It is an incredibly well-tolerated drug. Patients really have very minimal side effects. It's a pill that's taken twice a day for up to 2 years. It can be crushed and combined in water, apple juice, lemonade, pudding, yogurt, anything but orange juice, and is a little bit of a table of things that we should not, or you should eat in minimal amounts when you are on DFMO. It can be given by the NG or the G tube. And really, honestly, the most common side effects for the patients that have been taking it is either hair kind of arrest, meaning that their hair does not grow or that it thins a little bit. Significant alopecia or hair loss has not been noted all of that much, but it does improve once you stop the drug, which I think what makes this drug great is that once you actually stop the drug, all of the side effects go away. Diarrhea in the first few weeks to months definitely happens, and not in all patients, but that was fairly quickly. And then really what concerns many people at higher doses of DFMO is hearing loss. That is reversible. And in comparison to some of the platinum drugs that neuroblastoma patients go, this is not just in high frequency, it's across all levels, and so speech can be affected. So we take that incredibly seriously and check hearing a lot during the studies. But it is immediately reversible after you hold the dose. And if you drop the dose as well, that hearing loss usually does not come back. And so of note, that's not noted here, just in my own experience, I've noted a little bit of runny nose that kind of starts a couple weeks after you start the doses and kind of persists throughout it. And so from a hearing perspective, we always want to make sure that it's not fluid in your ear, but it is really hearing loss. So DFMO maintenance for relapse refractory neuroblastoma, a very important population, which I think anyone who takes care of neuroblastoma is trying to attack in many different ways. This study is built on a phase 1 study that was done a while ago now with combination of DFMO with etoposide at standard dose there, 50 milligrams per meter squared. In the original phase 1 study, there were 16 patients treated. And 3 actually have a CR or are fully in remission off of that study, which prompted the phase 2 study. Pretty impressive for a phase 1 study. And so as you can see here, we will be giving DFMO for 2 years and then the etoposide only for 6 months. These are answering important questions for patients who have had refractory, refractory neuroblastoma and patients who, unfortunately, about 17 to 20% of patients in upfront therapy will have refractory disease or progressive disease. And then arm 2 is patients who have previously relapsed and show no active disease at all, which is great. And then arm 3 is subjects who still have disease but are with minimally active disease. So this is a study prior to the arrival at Levine Children's Hospital, and I think this is, an important question. It's difficult to answer. But as I mentioned, a lot of patients unfortunately fail upfront therapy, and there are lots of opportunities to try. COG is trying some different modalities as well to try and get this there in the Beach Childhood Cancer Consortium. This is open at a few of their sites where it's been trying to target the patient's tumor exactly, looking for specific genetic alterations of the tumor. And so as you start your therapy, you get your first 2 cycles of induction, and then we add a targeted agent depending on the biopsy that we did up front, evaluating a precision medicine strategy. And really the question was, can we do better, obviously, and is it safe and feasible? And so the first 20 patients have been evaluated with no serious adverse with the addition of these, a smattering of these 4 agents. We still have to collect the data and review how well they did respond to that chemotherapy. And so this planned study also is asking the question of, well, if we want to try and target the stem cells, can we actually do that with antibody and retinoic acid? And that part of the study is a randomization where half the patients will get DFMO, antibody, and retinoic acid, and half the patients will not. but all patients after that 7-month period will get put on DFMO. And so really checking safety, making sure that it's tolerated the DFMO, and seeing if we can improve or lower that relapse after treatment rate. This is just a pictorial of what that looks like, and so I won't go through, but you know, the differences I think here from other trials is that in consolidation, the center that is running the study is allowed to choose a single transplant versus a tandem transplant. Other than that, it's fairly standard. And that's actually it. I wanted to leave enough time for pictures. These are 2 patients that have been treated through beat childhood cancer, just a cute picture to end on. And then I think really importantly, obviously Dr. Scholler, who started this consortium and has done a wonderful job. There are many, many people, and obviously with Kyle being the moderator for this, I definitely want to give a big shout out to the Beat Childhood Cancer Foundation. We really couldn't do any of this research without it. So to that, I'll turn it back to you, Kyle, and be happy to answer some questions.
Awesome. Thank you very much, Dr. Oesterheld, for talking about that. I know that we have a lot of questions in here, so I will raise some of them and let you talk about those. The first one from Jude Sibley. Hi, Jude. Is, as the data is so positive with DFMO, when, if ever, will DFMO be used in SIAPIN and COG frontline therapy?
That's a wonderful question. I mean, I think right now, the data, we have really checked that to check it in upfront therapy. I think that with most drugs, you try it in the relapse setting when it comes back. You also try it in a setting where the standard of care has been attempted and you're trying to improve upon that. I think if the data continues to look as good as it does, and really important is to make sure that it keeps going. So the 2-year mark, the 4-year mark, the 5-year mark, and make sure that that data looks great. And at that point, I think we would strongly consider running some clinical trials to bring that to the upfront. And as many of you know, the COG has embarked on a very, very big study, which will take a while to complete, with bringing MIBG up front, ALK positivity, and it's a really good trial for high-risk neuroblastoma patients. So obviously, we would like that trial to complete and see what that data looks like before we would ever do that.
Christina wonders, would you recommend DFMO maintenance for an INMIC non-amplified child that has no evidence of disease? Is there any benefit for non-INMIC patients?
Yeah, and I may have blown through that slide, but we definitely are noting that even in our NMIC non-amplified patients, a very popular question, since when you look at DFMO, it is about MIC amplified patients and polyamine inhibition, though it does attack the cancer stem cells. So we do think there is value in non-amplified patients. I can speak for the many patients that I have put on. They're probably about 50-50 NMIC amplified and NMIC non-amplified, and have had some success with that even in the relapse setting with non-MIC amplified patients. So yes, the answer is I would recommend DFMO population.
Okay, great. Could you just real quick stop sharing your screen so that we get to see you?
Oh yeah, my apologies.
No, that's great. Everybody likes to see more of your face.
All right, I'm going to try and do this and not screw it up.
Yeah, don't leave the meeting. I'll wait on that.
Hold on. I don't know why it's not. Let me get out of my.
There we go.
Did I stop sharing?
Perfect. Yeah.
Perfect.
Yeah, we see you a little bit better now.
Okay.
Someone has asked, many of the parents are struggling with maintenance therapy choices. I know between Sloan's vaccine and DFMO, those seem to be the two popular ones. They said, is there any way that BCC and Sloan could work together on some kind of combined trial? I think that's an interesting question.
It's a really hard question to answer. I think all of us in the pediatric oncology community work incredibly well together. Everyone has got their kind of opinions on what's going to work and what's not. And I've had patients, to be very honest, I believe in the informed consent process. And so I offer everything at the end of maintenance. And so that includes the Sloan Kettering vaccine. I've had many patients choose that and have done very, very well on it. And so right now, just because is hard to interpret the data with both drugs being given or patients being given. We have chosen to just give DFMO or just give vaccine. In the past, we did at BCC allow after vaccine to go on DFMO, but I think that limits some of the potential of knowing what works in that setting. I think my opinion on that is I do think that maintenance is important for neuroblastoma. And so I think many families that wrestle with the choice, I think I always practice the way that I would if it were one of my children. And I think that I would feel strongly that if that were to happen, I would want maintenance therapy. I hope that answers it. I think we do work together. I think as the science comes out, I think we're all excited about some of the things that Sloan is doing, the BCC is doing, T is doing. I think at some point, all those hopefully will be combined, but it is nice to have options.
Makes sense. Vicky wants to know, how do you know if the patients who received DFMO may have been the patients who would have done well regardless, especially now with the fact that children are receiving immunotherapy as part of the first consolidation?
Yeah, it's a fantastic question, which is asked a lot actually, and I think it's an important question to answer. And so, we have two data sets that we're looking at. So we look at all of the patients treated with high-risk neuroblastoma in the Beat Childhood Cancer Consortium. So that's called the historical data for BCC, as well as looking at some of the data for the Children's Oncology Group 0032 study, which is the landmark study for COG currently. And so I think looking at that information to make sure that you are not teasing out the good responders that got DFMO that did better, but putting all patients together. When we do that, looking at the data specifically for the FDA, it is continuously showing that there is about 10 to 15% improvement with patients after consolidation or immunotherapy. And so we believe that we are trying to answer that question statistically. It's a very difficult statistical question to answer. But we've got really smart people on it, and the FDA really pushes you to really look at your data clearly. And we're working with the COG to see what their data looks like in comparison to those patients that were treated with DFMO with COG. And so that collaboration is ongoing currently.
Okay, thanks. Spiros asks, how critical are the nutritional restrictions during maintenance? Do the banned foods interfere with the drug's efficacy?
Yeah, it's kind of interesting. Everyone has a little bit of a different take on that treats these children. I think the big one is not to give it in the restricted liquids. So orange juice being the one that give it there, it doesn't work very well. We know that. I think it's really hard. Most of these patients are 3, 4, 5 years old. And so some of these things are bananas and simple things like that. And so I think it is doing things in moderation like everything in life. And so I think that it's not a one size fits all. There are families who completely take away all foods. I think that's probably not needed. But I wouldn't eat the restricted foods every day, if that makes sense. And so I tell our patients that you can have things in moderation, but definitely do not put it in orange juice. But all docs that put patients on DFMO, I think, have a little differing opinions on that. And so some are a little bit more strict than others. Now that I have Dr. Scholler's ear every day, I have asked her the same question, and I think she thinks fairly similar to what I answered, that everything in moderation is probably appropriate.
Okay, yeah, I hear that question a lot. So let's, thanks for
asking
that. Carrie says they're scheduled to start DFMO at the end of the month. And if patients are not completely in remission, are there still options to enroll in the study?
Is that after upfront therapy? I apologize.
She doesn't say, she just says.
Yeah. Yeah, there is an arm on the DFMO that would be with etoposide for patients with disease right now. We are not giving single agent DFMO, but we are adding etoposide to that. That's the newest trial that's come out of the consortium. But yes, there is that patient would have an avenue to getting DFMO currently with the BCC trial.
Great. Then another one here, is the dose escalation to 25 milligrams also for patients who are in remission before starting immunotherapy? According to the trial site, these patients will enroll to a different stratum.
Yeah, so that dose escalation is going to be, so patients who have no evidence of disease will still be at the 1,000, and the increased that only population that will be at 1,000. Every other patient will be at the 2,500 per meter squared.
One person wonders what happens after 2 years. How is the ODC1 pathway blocked after that? Why 2 years?
You broke up a little bit there, but I think the question was what happens after 2 years?
Right. Why is it 2 years? They say, how is the ODC1 pathway?
Yeah, I think for me, 2 years, you have to make a kind of line in the sand somewhere. And so that data was just showing that 2 years was kind of leukemia maintenance therapy. It used to be 3 for boys, 2 for girls, and now there's a 2-year mark. I think that seems to be fairly standard. In some of the other trials for sarcomas, it's a 6-month maintenance period now. And so I think maintenance is going to be important. It's hard to know if it's a year is the important date or 2. The data, unfortunately, is on the 2-year mark because I think that I was not involved in that, but I think the thought was more prolonged suppression of that cancer stem cell was going to improve.
Okay, great. And then someone says, I understand kids in second remission are now required to do 6 cycles of etoposide and DFMO before they can do DFMO alone. Generally, these kids have had a great deal of chemo already through the years, and they're curious why we'd advocate a child who's NED would have more chemo and toxicity.
Yeah, it's a fantastic question. Questions that were asked in the scientific of that study. I think that the answer, simply put, is the data with DFMO alone was still fairly low at 45 to 50%, with some of the phase 1 data showing that etoposide improved the reduction of that cancer stem cell as well as the active disease that the patient had. It made sense to try and improve that because we had already tried DFMO as a single agent, and the expectation with etoposide is that hopefully, obviously that's why you do the study, is that will improve those patients that actually go into a full remission from that, and then stay into a remission if they have no evidence of disease, because we still think that cancer stem cell is there. That's a great to know, but I think it was something difficult for scientific review to decide upon, and went back and forth, but we felt the preliminary data was strong enough that etoposide was a good addition.
Okay. Helen is asking, when can we expect to see DFMO FDA approved? How is this process going?
The process is going fantastic. And so I could spend probably 2 hours going through this, as I have been involved since the beginning of the year with the recruitment of Dr. Scholler to my site. I think it's going very, very well. There's obviously looking at all of the statistics that need to be done, but breakthrough status was a big deal. And we have another FDA meeting at the beginning of 2021. Unfortunately, with the situation globally with the pandemic, things got slowed down a bit. And so no real timeline. All I can say is I think we're excited about the opportunity. We have a good company that has bought into this drug and believes that they can get it FDA approved. So we're really excited about that, and really trying to bring that to patients in a commercial way and off study would be great. So I think, the optimist would say a year or 2, the pessimist probably say 2 to 3, but I think we are optimists here, and we're trying really hard for it to be quick, because we believe it should get into the hands of our patients.
Yeah, I've been on that for a decade now, so it's been a long journey, and I know everyone is ready to make that happen. Someone asks, is there any data on the current trial with chemo/IT, I'm not sure what that is, and DFMO as it relates to success?
Yeah, I don't. I mean, I think that I'm assuming they're referring to the new COG study with randomization of IT and antibody with DFMO, and that's unfortunate. I don't have access. That's a COG study, and it's fairly new. It's an exciting study, though, to add DFMO to that regimen, which, as many people who treat neuroblastoma have realized, that's a very good way to get our patients back into remission. And so, but no, I do not have that data, but I'm excited to see what that data shows.
Oh, irinotecan. Okay. How many have been randomized so far on the antibody plus or minus DFMO portion? Is a question.
That is I asked the question, and please don't quote me on this, but it's roughly about 100 patients have been enrolled on that study. About 85 to 100. I don't know. Unfortunately, enrollments kind of come in batches, but a sizable portion, about 85 to 90 patients, and maybe a smidge more.
Okay, great. Just a couple left here at the moment. Spiros also asks, are you taking into account the Australian research that combines novel polyamine blockers with DFMO, like AMXT 1501? And would this trial be enriched with new agents eventually?
Great question. I think we always have to keep an eye out for stronger poly inhibitors. And I think that I don't know that data offhand, but I think that we are always looking to see if adding a different agent is better or worse. There are definitely agents that are continuously coming out for other diseases that are improving upon the original. And so it's something to look at, but currently we're not working with the Australians, and but definitely something to consider.
Okay, only one left on here. So anyone else, we do have a few minutes left. So if there's other questions, please type them in. I will read this last question that we have for now. This person was told they'd be enrolled into stratum 2. They were treated by MSK and not COG. But they'd like to enroll into the arm receiving the higher dose and want to know if that's possible.
Hard to answer on a conference. I would say we'd have to see how that patient did and where they are and everything else. My email is readily available on the BCC site. You're more than welcome to email me with some of the specifics, and I can speak with Dr. Scholler and myself, and we could kind of give you an answer, but hard to answer on a conference. There are some pretty specific rules to who gets onto which.
That makes sense. Okay, one last question just popped in here then. A question about the recent paper results. When broken down to in-MYC amplified or non-amplified, the data do not show statistical significance. Is there any comment on that? Is it because of the small number of patients?
It's another great question. I think small numbers, I think some of the data is still being analyzed. I think that hopefully that was preliminary data that was published. And so I think we have noted that the survival curve does benefit, and so some of the statistics very complicated because of the small number of patients. And so our hope is to be able to show that shows cancer stem cells, but that's why you do the statistical analysis, and we're really just kind of delving into that for the FDA as well right now. Great question.
Yeah, can children elect to join the maintenance portion of the antibody plus and minus DFMO without enrolling on the beginning of plan?
100%. That is actually what we're pushing really aggressively now, just because we have met the endpoint or about to meet the endpoint for the first part of that study, and that's called Part B of that study. And to be honest, at our site, that's what we're doing for patients who did not want to be on plan. We offered the COG and plan and patients elect both at times, and so elect one or the other. And so many of our patients would like to have DFMO randomization that is built into the study.
Does Levine welcome international patients? What's the capacity and volume there?
Well, that is a wonderful question. Yes, we do. We actually have a wonderful group called Global Health Services. Like I mentioned, we have been the home institution since July and have seen about 20 international patients. Obviously, with COVID numbers increasing, the borders are starting to close again. So that is the biggest restriction currently. Once that restriction is lifted, we do not have any of that. We have seen patients from Singapore, Hong Kong, Australia, South Africa, UK, so far first 6 months of housing the consortium. So we're really excited about that. Global Health is wonderful. They work with our families to make sure that the finances are set, that patients are brought to our institution, have concierge services. They will pick you up at the airport. They will bring you to our clinic. It's incredibly stressful. We have housing set up for you. And so it's an incredibly streamlined wonderful thing. And Charlotte is the second busiest airport in the country. So flights are mostly direct from everywhere. So we're excited about that. And we have increased our volume significantly. I think people like Charlotte International more than Grand Rapids.
I know it's easier for me to get there.
That was a joke for all the Grand Rapids people. We love Grand Rapids, but easier to get to Charlotte.
That's true. This is an interesting one from Laura. Why, in your opinion, are international specialists skeptical of DFMO?
I don't exactly know how to answer it. I mean, it's hard to get into the brain of all those people, but I think, you know, if you look at the data, obviously this community doesn't know me very well, but I am incredibly skeptical as well. And so Kyle knows that probably, but I think that the reality of that is once you take care of these patients and you put patient DFMO, and so I've been taking care of neuroblastoma patients for a really long time. And so to see those patients who historically would not have survived or on DFMO and are surviving, it's kind of a testament to that. And I think that you're skeptical until you see the data, right? We're scientists first, and I'm going to be skeptical about DFMO making a change outside of 5 to 10 years to make sure that we see that. Everyone is taught as an oncologist that that's what you need to see. And so I hope, you know, for our patients specifically, that the data holds and that we see improvements. You know, if you look at any clinical trial that has really robust data, the first couple of years, a lot of those studies look great. And then unfortunately, over time, patients relapse and succumb to their disease. And so I think we're trying to be cautious that that is not occurring in DFMO. And then obviously the commentary out there that, and someone already asked this, are the patients on DFMO the better patients, right? Are DFMO patients the ones that would have survived regardless? And I think that our data hopefully will prove to the community that that's not really true and that all patients are in that data set. But the numbers are small, so easy to be skeptical. But I do think as the numbers grow, I think this data will hold.
That is great. I'm getting a message here. Let's see here. Donna says, just thank you. This is an excellent presentation. She really appreciates your time, so that's nice. Thanks, Donna.
Thank you very much.
And then I guess we've got just a couple minutes left. So Kelly wants to know, how do you measure remaining cancer stem cells?
That is the great question, because we are trying hard in all different diseases to find that. Some people are looking at it in blood. It's you know, circulating DNA and things like that in our sarcoma populations as well as neuroblastoma. Right now it's a blood analysis, but it is not there. I don't think there's any that have been fully accurate and that you could hang your hat on 100%.
Okay. And all right, tech pet, I'm seeing from the tech people, we can get back to these unanswered questions, but there's only one left, so I'm going to ask it anyway. Do we really need a randomized study in order to appreciate how good DFMO is? Don't we already know the survival rates from the frontline therapies?
Wonderful question. I think that if you are a diehard DFMO believer, you would agree that no, we don't need a randomized study. But in any good clinical trial, randomization is the gold standard. Do I think that based on historical control, we need a randomized trial? I think it's yet to be seen. But my take on it is, I think we likely don't need a randomized study. That'll be an important question for the FDA for approval, and I think we're having those conversations currently. It's a very good question. I think there's a lot of people who feel we don't.
Right. Well, thank you, Dr. Oesterheld, for walking us through all that, for being here. Thank you to everybody who watched and sent in questions. There was a lot of questions, and it's great. I wish that I was able to be with you all in person, but hopefully next year we'll make that happen again. That's the end of this session. Next up, we will have the bivalent vaccine studies. So head over to the Watch Live page on the event website. And as Dr. Oesterheld said, his email is readily available on research.beatcc.org. So you are welcome to email him any other questions. I know he loves to receive those. And then remember, if you do miss a session or any of the sessions that have happened up until today, and the other ones happening, they will be available to watch shortly after the live session on the on-demand page on the event website. So check that out, and hope the rest of everyone's days are well. And thanks for being here.
Thanks a lot.
All right.